Good morning, everybody. Welcome to today's webinar. This is the first in a series of webinars hosted by the National Collaborating Centre for Infectious Diseases on the topic of corrections as a public health setting for sexually transmitted and bloodborne infections. My name is Susie Taylor. I'm a project manager at NCCID. I'm primarily focused on sexually transmitted and bloodborne infections, and I'll be your moderator today. The National Collaborating Centre for Infectious Diseases is funded by the Public Health Agency of Canada to provide knowledge, translation, and evidence for use in public health planning and policy. We're hosted by the University of Manitoba, and I'd like to acknowledge that our offices are on Treaty 1 territory, the homeland of the Anishinaabe, Cree, Ojibwe, Dakota, and Dene people, and on the homeland of the Métis Nation. Before we get into this, the webinar, I'd like to go through a few household items. The event will be recorded and it'll be available on the NCCID website later on. There'll be a question and answer session at the end of the presentation, and you can use the Q&A tab to pose content-related questions as time allows. We will try to get to as many questions as we can, but it's possible we won't be able to get to all of them today. The chat will be disabled during the webinars, except for the host and panelists, so that we can share resources with attendees. The recording of the presentation will be available on nccid.ca in the webcast section of our website, so you can look for it there. I'd now like to introduce today's speaker, Dr. Sophia Bartlett, and welcome her. Dr. Bartlett is the Senior Scientist for Sexually Transmitted and Bloodborne Infections at the British Columbia Centre for Disease Control. She completed her PhD in medicine at the University of New South Wales in Sydney, Australia, and then undertook her postdoctoral fellowship at the University of British Columbia. She's a co-investigator with the Canadian Network on Hepatitis C, with CIHR's Canadian HIV Trials Network, and the BC Hepatitis Testers Cohort. She's also the lead of the UMatter Pathways to STBBI Care in Prisons project, which we'll discuss today. So without further ado, welcome, Dr. Bartlett.
Thank you, Susie. Thank you for the invitation to present this webinar. So as Susie said, please use the Q&A tab to pose any questions. If you have any troubleshooting questions, this is the email address that you can contact. These are my disclosures. I do not accept any personal payments from commercial entities. So the objectives for this session are to learn about the importance of addressing STBBIs in correctional settings, the current evidence for models of care and interventions to enhance STBBI testing and linkage to care in prisons, to learn about the UMatter project, the rationale and the methodology, and to learn about the current best practice recommendations for the provision of culturally safe and trauma-informed STBBI testing and care in correctional settings in Canada. I'd also like to start with some acknowledgements. I'm an uninvited white settler on the unceded ancestral and continually occupied territories of the Coast Salish peoples, including the Musqueam, Squamish, Stolo, and Tsleil-Waututh nations. I would like to thank all the people with lived and living experience of incarceration who have generously shared their knowledge and expertise with us during this project. And I would also like to thank the UMatter project team members, past and present, who've all been wholly committed to this work. We began the project right at the beginning of COVID, and so it's been quite challenging having to pivot a lot of the methodology and all maintain engagement virtually all of this time. So a special shout out and thank you. This is a photo that we took during one of the only in-person sessions that we ever had. We're all meeting for the first time, for some of us in person. And there's been a number of different people who've been part of the core team at different times. So I just wanted to thank them all now, as well as the Public Health Agency of Canada for the funding to support this project, and the Provincial Health Services Authority in BC, and the British Columbia Centre for Disease Control for hosting the project team. I would also like to acknowledge the enormous number of people who have been part of the Stakeholder Committee and who have also reviewed and contributed in other ways, as well as the organisations who've supported this project. It's been very collaborative, and this work would not be possible without all of the support from these people and organisations. So thank you. I would also like to begin with a note about language. Words matter. The words that we choose and that we speak can either help or harm. It's okay to make a mistake or decide that you want to change something. Just because we used different words in the past doesn't mean that we have to keep using them. The most important thing is that we try to reflect on our choice of words and that we choose words that will foster trust through respectful communication. So my personal commitment is to see the person and say people first. So I'll use some abbreviations in the slides throughout this webinar today that you might not be familiar with, but I hope you will be soon enough. You'll see people who are incarcerated abbreviated as PWAI, and you'll also see people with lived experience of incarceration abbreviated as PWLE. We've recently published a commentary calling for person-centered or person-first language for people in prison and people who were formerly in prison, and I'd invite you all to seek that out and read it. And it's an invitation to consider the language choices that we make. And there are other very great resources out there, particularly this COVID-19 language guide from the BC Centre for Disease Control, which also includes a section on person-centered or person-first language for people who are involved with the criminal justice system. So I'm going to start with an overview of the correctional system in Canada and British Columbia, just as background information for everyone. So the correctional system in Canada is split into two separate entities, and it's based on the sentence length that a person has. So people with a sentence of more than 2 years will serve that period of custody in a federal institution. These are institutions that are managed by Correctional Service Canada. They're spread throughout the country. And then people who have a sentence of 2 years less a day, or who are on remand, which means that they're unsentenced, or who currently are on immigration detention or an immigration hold, they serve that period of custody in a provincial or a territorial correctional centre. And this results in having 14 different correctional systems across Canada, and they all have a different standard of care. And it's important to note that the heterogeneity in care in corrections disproportionately affects Indigenous people in Canada, because while they are only 5% or less than 5% of the overall Canadian population, Indigenous people actually are 47% of the incarcerated women in Canada, and they are 30% of the incarcerated men in Canada. So when we're talking about heterogeneity in care and the standard of care in corrections, this is actually a critical health equity issue, particularly for Indigenous people. And touching on women in the correctional system in Canada, overall, the number of people in prison in Canada actually decreased over the last 10 years. But concerningly, the number of women increased among the prison population. Women who experience incarceration in Canada are more often from a low income background. They have lower levels of education and more sporadic employment histories, and they're often the primary caretaker for children. Women who are incarcerated in Canada are more frequently incarcerated for non-violent and survival-based crimes. In British Columbia, there are 10 provincial correctional centres, and these are managed by the Ministry for Public Safety and the Solicitor General. There are 2,422 cells in total in the BC system, and in 2018, the average daily count of people in custody was 2,393, so they're very close to being at capacity. Responsibility for healthcare in British Columbia Provincial Correctional Centres was transferred from the Ministry for Public Safety and the Solicitor General, or PSSG, to the Provincial Health Services Authority in October of 2017. And a new program was created in BC Mental Health and Substance Use Services, which is a program in PHSA for correctional health services. Now, BCMHSUS has a mission to provide culturally safe, person-centered and trauma-informed care for their clients. And so this actually kind of fed into the rationale for conducting this project. Among people who are in custody in British Columbia Provincial Corrections, 63% at any one time are actually on remand or unsentenced. The average length of stay is 38 days for people on remand, but it's only 65 days for sentenced people. So as you can imagine, the provincial system actually has a very large number of intakes and releases each year in BC. And this is similar across Canada. In 2018, there was 22,000 individual admissions to British Columbia Provincial Corrections. At any one time, about 69% of the adult custody population in BC Provincial Corrections actually has a diagnosed mental health or substance use disorder. 42% of them actually have both a diagnosed mental health and substance use disorder. And at any one time, 1/3 of people in adult custody are actually receiving opioid agonist treatment in BC Provincial Corrections. Incarceration really perpetuates and amplifies a lot of health inequities. And as you can imagine, based on those statistics that I just mentioned before around the proportion of people in custody who have a mental health or a substance use disorder, it's really due to laws and policing disproportionately selecting people who use drugs, people who experience mental illness, people who are unstably housed or financially marginalized. And this results in those groups becoming concentrated in correctional centres. At entrance to custody, we see medications being ceased or interrupted. Health history can be unavailable sometimes. Therapeutic relationships are lost. There's a lot of anxiety, fear, and stress. And of course, if you were housed and employed before entering corrections, those things actually become disrupted. And so then during incarceration, we see often a deterioration. Mental health can deteriorate, STBBIs and mental illness are highly stigmatized, and so people are less likely to seek care. There are other barriers to accessing information. You can't Google something when you're in prison because you don't have the internet. And then when we see people eventually released to the community, and of course the majority of people in corrections eventually do go back to the community, we see a lot of stress with that transition. People have competing priorities, and services, when they exist, are actually very hard to access. And so this cyclical pattern actually ends up exacerbating a lot of the problems that people had in the first place. And often we see people returning to the community not in actually a very good shape. And impacting all of these things on top of that is the ongoing impacts of colonisation in Canada, racism in healthcare, particularly anti-Indigenous racism, the stigma and discrimination towards people who use drugs, and all of the other kind of social determinants of health. These kind of health impacts of incarceration were noted in the Nelson Mandela rules. These are rules that were created by the United Nations Office for Drugs and Crime. And there was a particular emphasis on health for people who experience incarceration. Rule 24 in particular states that people in prison should enjoy the same standards of healthcare that are available in the community and should have access to the necessary healthcare services free of charge without discrimination on the grounds of their legal status. So really setting a basis that the same standard of healthcare that's available in the community should be what's available in corrections, and that the healthcare services should be organised in close relationship to the General Public Health Administration. So why do we need STBBI policies and guidelines for correctional settings? Well, first of all, what are STBBIs? They're sexually transmitted and bloodborne infections, which include but are not limited to HIV, which is the virus which causes AIDS, hepatitis C virus, hepatitis B virus, syphilis, chlamydia, and gonorrhea. It's a combination of bacteria and viruses. Most of these have no symptoms or very vague, non-specific symptoms. So the only way to know for sure if someone has an STBBI is to be tested. And for historic and ongoing reasons, STBBIs are highly stigmatized. HIV stigma, for example, is perpetuated by the criminalization of people living with HIV for HIV non-disclosure. And these infections can have serious and life-threatening complications. Prisons, in fact, concentrate, amplify, and disseminate STBBIs. As I mentioned before, we see people who are more likely to have an STBBI concentrated within the prison system because of laws and policing disproportionately selecting people who use drugs, people who are involved in sex work, and people who are from marginalized backgrounds experiencing unstable housing and things like that. When people go into the prison system, there is a lack of harm reduction. And so we often see STBBIs being amplified within the prison system through transmission. And because of barriers to accessing healthcare, people's health can actually deteriorate while they're in prison. And eventually they go back to the community, and then STBBIs can be disseminated. And when people go back to the community, they face barriers to accessing care. So morbidity and mortality are actually increased, particularly for people living with HIV. There's a lot of evidence that prison disrupts people's access to antiretroviral therapy. And of course, this is a cyclical process. So we just see it being amplified continually. And this has resulted in STBBIs being highly prevalent among people in prison globally. For both HIV and hepatitis C, we see this pattern particularly linked to injecting drug use and the prevalence of people who inject drugs being incarcerated. In Canada, the prison population includes an estimated 12,000 people living with hepatitis C infection. This is 30 times higher than the prevalence of hepatitis C in the overall population in Canada. There is some good news though. STBBIs are preventable and treatable, and these medications are becoming increasingly effective. In fact, hepatitis C medication is so effective that with the scale up of testing and treatment, it's actually possible to eradicate the infection from entire prison systems. And we've seen this happening in quite a few prisons now. For example, in Delaware, between 2003 and 2019, they had a decrease in hepatitis C prevalence. It went from 23% just to 1% through scaling up access to hepatitis C testing and treatment for people who are incarcerated. So where should hepatitis C and STBBI testing levels in correctional settings be? Well, we've seen high levels of hepatitis C screening and treatment in corrections is key for hepatitis C elimination efforts to be successful. In some of the prisons where hepatitis C has been eliminated so far, they're seeing at least 90% of entrants receiving hepatitis C screening. It's estimated that up to 40% of women and up to 30% of men provincially incarcerated in Canada are actually living with hepatitis C infection. But in BC in 2020, among all intakes to provincial corrections, our estimate was that 23% of people had a hepatitis C test ordered that year. So we're not really at the level that we want to be at. And we believe that we're actually far under testing compared to where we should be to ensure that all people living with hepatitis C in the provincial system are aware of their diagnosis. We've seen in the literature many barriers to hepatitis C testing in corrections identified previously, which explains these kind of low numbers of people receiving hepatitis C tests or knowing their status in corrections. So policies and guidelines that set out what care for STBBIs should be provided and how it will be provided are vital in being able to streamline and improve testing and care for STBBIs, both during and after release from prison. So the question is, how can we improve both the uptake and the quality of STBBI testing and care in prisons? Well, we looked to the IAP2 Canada spectrum for engagement. And we looked at all of the different options that were available in terms of how we could come up with solutions to improve STBBI testing in corrections. And looking at this spectrum, you can see that there's sort of an increase to the impact of the decision as we go along the spectrum. And so we actually settled at the collaborate stage. So this is partnering with people in each aspect of the decision, including the development of alternatives and the identification of the preferred solution. And so that's where the STBBI Pathways to Care project came from, also known as the UMATTR project. So what we wanted to do was actually partner with people with lived and living experience of incarceration as the experts on this topic. So the project is based on the idea that people with lived and living experience of incarceration, as well as the people working in correctional centres, need to be involved in creating the policies and guidelines that will shape their care. And so the project set out to create STBBI screening and linkage to care policy recommendations and guidelines for BC Provincial Corrections, including input from research, as well as key informants, including the clients, so people who are incarcerated, the people who are responsible for care, so correctional officers and correctional health services staff, as well as other project partners, so people with lived experience of incarceration, people with lived experience of STBBIs, researchers and community organisations. And in terms of how we set out to actually conduct this project, we had a vision for the project journey. Obviously, this was all conceived before COVID, so we had to pivot and kind of adapt to what we were able to do. Originally, we were planning to do in-person engagements to build relationships and build trust, but everything had to be done virtually. And what we did was we started with building capacity. So we conducted virtual education sessions for all of the stakeholders, as well as creating online courses and other materials to make sure that everybody started off on the same level in terms of their knowledge on this area. Then phase 2 was listening and learning. We conducted surveys as well as virtual focus groups with all of the stakeholders to understand what people had experienced in the past, what their needs and preferences were, as well as to kind of build engagement in the project. The next step was creating a draft of recommendations based on the stakeholder input. And then we went back to all of the stakeholders to get feedback and revise and reiterate the draft. And now we're at the point now where we're actually implementing and evaluating. So handing over the set of policy recommendations and the guidelines to correctional health services to implement, and then BC Centre for Disease Control will be supporting them with the evaluation. And of course, in the future, we're hoping to scale and spread. And I'll share the webpage that we've launched that houses all of these materials along with other tools and templates, and really hoping that this can kind of spur a bigger discussion around both improving the uptake of STBBI testing and linkage to care, but also really focusing on the quality of care that we're offering. I'm going to step you through the sort of methodology that we've used for these, as well as our preliminary results from all of the engagements and the recommendations. So in stage 1, building capacity, we conducted quite a few different formats in terms of the engagements, and we also created a few different knowledge products. So one of the things we created was a deck of playing cards, which actually has a combination of STBBI facts and random facts. And this was developed with people with lived experience of incarceration. And the STBBI playing cards are available on the website. We also created fact sheets and then an online course for correctional healthcare staff. It's STBBI Basics, about 60 minutes to complete, as well as an online course for correctional officers, which is about 20 minutes to complete. And both of those also include fact sheets, which can be downloaded. And so we actually invited all of the stakeholders to participate in these. It was all voluntary, but we did have really great uptake and also really encouraging evaluations from the people who completed these courses. They're all available online at the website. In stage 2 for listen and learn, we conducted surveys as well as focus groups. We had engagements with 186 people with lived and living experience of incarceration, 103 correctional officers, and 41 healthcare workers working in corrections. And we asked a number of different questions in order to inform our recommendations. But one of the key ones that we were really hoping to learn about was the preference for the method of testing and consent. And there was really this overwhelming, very strong preference from all of the stakeholders that people only be tested after they give consent. Now, this is potentially something that's unique to British Columbia, but in emergency departments in BC, there is actually HIV testing conducted where people don't necessarily consent. They're not aware that they're being tested. In BC, this is known as opt-out HIV testing. And so for us to understand what people's preferences were, particularly because we're not just talking about hepatitis C testing, when we're talking about STBBI testing, so it includes HIV, hepatitis C, syphilis. And so understanding what people's preference was in terms of how they be tested and that they all really strongly agree that people should be told that they're being tested for something, or that they're being offered testing for something, and that should only proceed after they explicitly consent to it. This was really important for us to understand, and to really kind of reiterate that consent-based procedures in corrections are really important, particularly because there's a power imbalance here. We also heard from all of the stakeholders that stigma was a top barrier to being tested for an STBBI in corrections. It was actually the most frequently selected barrier. This is, kind of concerning. There's a lot of emphasis on stigma, particularly around HIV in the community, but knowing that people who are incarcerated would actually not get tested because of fear of stigma is really, really concerning. We also heard around when testing should be offered that there's actually no perfect time to offer STBBI testing in corrections. And in fact, I'll discuss the recommendation for this, but we heard a lot of suggestions from people who are incarcerated around when they feel that testing would be best to be offered. And while the majority of people said intake was the best time, we then heard these conflicting kind of preferences around actually just after intake and sort of other opportunities for testing. And then this kind of, I guess, blanket over everything, which is privacy concerns. And we actually suspect that the stigma and the privacy piece is actually kind of interrelated, in that people in custody, people who are incarcerated, actually don't fully understand the privacy and confidentiality policies that healthcare providers in corrections are actually bound by, and that they don't necessarily trust that the policies are being followed. So we're also recommending quite an emphasis on education around the policies and making the policies more visible. So kind of actually explaining to clients when they're signing a release of information consent form, for example, that their healthcare information can only be shared with their consent, and other ways to enhance privacy and confidentiality, particularly around STBBIs in corrections. We saw that this was particularly important for people who responded to the surveys who identified as part of the LGBTQ2S+ community. And so this was really quite important in terms of providing trauma-informed and person-centered care. In terms of what we heard in the workshops, this really mirrored what we saw in the surveys. So the qualitative data really supporting the quantitative data. We heard a lot about the privacy limitations in corrections from both people with lived and living experience and healthcare workers. There was also a lot of discussion around trust, and it was interesting to contrast the two kind of positions. People with lived experience often said things like guards are gossiping and they don't take things professionally. And then healthcare workers also supported this idea that there's a bit of a misunderstanding. So clients thinking that they're sharing information with corrections, but they're actually not. And that there's this kind of baseline level of distrust. We also heard a lot of opportunities to increase knowledge. People with lived experience really echoing that there was other ways that education could be provided in corrections other than just pamphlets and things like that. A lot of correctional centres now have TV systems where a video can be played on all of the TVs throughout the correctional centre. And people identified that as a potentially really effective way to increase access to information and education. And correctional officers really identified that increasing education for them about STBBIs would really help them understand what the benefits of enhancing this care were and really build support for scaling up STBBI testing and treatment. Of course, in a lot of cases, correctional officers actually have to escort people around correctional centres. So when there's going to be more appointments for things, it will impact correctional officers' jobs. And so it is important to inform them about what's happening. And we heard this really strong desire for engagement. One of the people with lived experience had this quite poignant quote. He said, This is the first time in my 30 effing years of going to jail where I've been asked to give input. And correctional officers also felt like it was valuable having the opportunity to provide input. So we really think that this type of collaborative process actually could provide benefits for developing other types of policies and guidelines, but also building in mechanisms to get input and feedback from clients and staff just in general will probably be a way to ensure the long-term sustainability of the policies and the guidelines, as well as to increase engagement in general. Of course, in correctional settings, there is this overarching safety issue that kind of cuts across everything. So correctional officers said, all drugs create security issues and should be actively removed by correctional staff. And then people with lived experience shared that, there's a lot of unsafe injecting practices happening within corrections, just really out of necessity. So, sharing needles between 12 people. Correctional healthcare workers also sharing that, correctional staff are always in earshot, and that's for a security reason. And so there's not a lot that they feel that they can do about that. After we took all of this input, so the surveys and the focus group data, we reported this back to our stakeholder committee. So we had a multidisciplinary committee who met every month over the past 2 years. It includes people with lived and living experience of incarceration, people with lived experience of STBBIs and substance use, as well as researchers, healthcare providers, and decision makers. And they were reviewing input from the focus groups and the surveys as that was available, and determining what should be incorporated into the policy recommendations and guidelines. We also had done an environmental scan at the beginning of the process, and so identified relevant evidence from the literature, as well as other guidelines and other policies that existed. And so also synthesizing all of those pieces together. And then the core project team wrote a draft set of policy recommendations and guidelines based on this input. And then we took it back to our stakeholders. So in the second iteration, we had 16 people with lived and living experience of incarceration who sat down to do workshops with us, 16 correctional officers and 13 healthcare workers. And I'll share the recommendations that we came up with after receiving their input, and some graphic recordings from the workshops that we did with people with lived and living experience that really helped us inform these recommendations. So what are we recommending? Well, first of all, it's really important to address stigma. So this is not an easy task. And in fact, all of these recommendations kind of work together and support each other. So the first thing to address stigma is promoting person-first language. This is going to help with building trust and reciprocity, and then increasing the availability of STBBI information in corrections. Education and information is a really important way to address stigma, because a lot of what drives stigma is misconceptions and people actually not having access to the facts. We also think that normalizing STBBI testing will be important to address stigma. One of the ways that we're suggesting that STBBI testing can be normalized is actually incorporating it as part of an offer for other tests that would be available for people in a sort of primary healthcare setting. So at the time when STBBI testing is offered, that's actually part of a offer of more primary healthcare assessment in general. So including liver health screening, so looking at the liver enzymes and other possible causes of liver disease, such as alcoholic liver disease, fatty liver disease, looking at kidney health, screening for type 2 diabetes. All of these things could be integrated together as part of a more whole and wellness approach to STBBIs. Enhancing privacy and confidentiality. So there was some suggestions for correctional healthcare workers from correctional officers around how they could enhance privacy and confidentiality. Some of the things are quite simple. So for example, there are some areas within each correctional centre clinic that have a little bit more privacy in terms of, sound and things like that. And correctional officers suggested that, more conscious choices in terms of going to that other room to have a discussion could actually enhance privacy and confidentiality. But in general, one of the big things that healthcare workers and correctional officers identified was that there was just a misunderstanding among clients about what the policies actually were, and that being more visible in terms of increasing the awareness and the education on those policies for clients could actually help them to become more trusting and understand that their healthcare information is not being shared without their consent, and that there are only very specific cases where healthcare information is shared without their consent, and that in fact it's usually being reported to public health, not to corrections. There was also suggestions to review medication dispensation procedures. There was discussion around things like having all of the people who are receiving medication lining up together to receive medication, and that this could particularly compromise privacy and confidentiality for people who are living with HIV who are receiving their antiretrovirals. And so while it might not be possible to change some of these, at least reviewing the procedures and having a discussion around what alternatives could be in place would be recommended for correctional centres. And of course, tying all this together is increasing STBBI education. We actually saw a lot of engagement from correctional officers and quite high acceptability of receiving the basic STBBI education. And in fact, a lot of them reported that they would be very happy to take an STBBI course when they begin working in corrections and annually as well. And correctional officers actually have professional development time allocated to them. So adding in an STBBI course as something that's available for them to complete during their professional development would be a very effective way to increase STBBI education for that group. For healthcare staff as well, and in fact, all of the staff working in the healthcare clinic. So that includes medical office assistants. Having access to STBBI education for them is also a really effective way to ensure streamlining of the policies and procedures, but also to ensure that they understand the importance of all of the recommendations. And then across all of this is education for clients. We did see some correctional centres had some programming available, but it wasn't the same programming in all of the correctional centres. And it wasn't programming that was actually something that was ongoing or guaranteed to be happening all the time. So we're really recommending that correctional centres invest in providing ongoing programming, or at least ensuring that a certain set of sort of brochures and pamphlets and posters and things like that are available across all of the correctional centres. We're suggesting that STBBI testing should be offered to everybody entering custody and that it should be offered multiple times. So we heard from participants that offering a test at intake would be an effective way to ensure that everybody gets offered testing. But in fact, intake is not a very pleasant time for people entering custody. A lot of the time, they're actually experiencing opioid withdrawal or withdrawal from other substances. It's actually a very long process. It's up to 8 hours in a holding cell and a lot of interviews and things like that. And so a lot of the time we heard from participants that they were actually just wanting to get to their cell that they're actually going to be living in, have a shower, eat something and go to sleep on that day, and that they're probably not going to be receptive, particularly if it's about having a conversation about STBBIs. But the recommendation is to plant the seed at the intake health assessment. So providing a postcard or some other type of information for everyone, telling them everybody entering custody gets offered STBBI testing. It's available at any time, and you're going to have a follow-up appointment booked for you where we'll be talking about the STBBI testing, and that appointment should be within 24 to 72 hours after intake. So the optimal window to actually have that discussion and ensure that everybody gets followed up, so really accounting for the short sentence lengths, would be within 24 to 72 hours after intake, and that should actually be a dedicated appointment that's made. It doesn't need to be made with an MD. It could be with a nurse, an RN, or an LPN. And the point of that appointment is to have a discussion about the previous tests that have been done and what those results were, which is the next recommendation, as well as any other concerns that people have, really making sure that the approach to STBBIs doesn't overshadow other concerns that people who are incarcerated have, as well as offering the testing again and tracking if it was offered at intake, if it was received after intake, and ensuring that people who actually didn't take up that offer at the first chance will get offered it again. So it's about saying this is important enough that we're actually going to bring it up multiple times. So for example, at intake to OAT or other health encounters, and making sure that all clients are informed that they can request testing later if they want at any time and how they should do it. And as I mentioned before, the next recommendation is reviewing previous STBBI test results. Now in British Columbia, we do have a provincial system which allows healthcare providers and certain health authorities to see all of the tests that someone's had done and what those results were. Not every province has that, but if it is available, we recommend that previous test results should be reviewed before offering STBBI testing to clients. This is particularly important for hepatitis C because we've seen a number of people who in the provincial system have had repeated positive antibody tests ordered, but never getting the RNA test ordered. In BC, we now have reflex RNA testing, but it actually is not an algorithm that picks up every single person. So it is still important to review those previous test results. And also reviewing if there's ability to do this, other medications that were dispensed. For example, if someone recently completed hepatitis C treatment, you'll want to check, did they have their SVR12 assessment? Was the hepatitis C RNA ordered? That would be a good time to order that SVR12 test and then identify the provider in the community who you can copy the results to so that they know what the outcome of the treatment was for their patient. And in fact, we're actually recommending that clients be asked as well what other treatment they had received in the community and who they were receiving that from, because we heard from a lot of the hepatitis C treatment providers especially, that oftentimes they've actually been working with a client and getting them ready for hepatitis C treatment, and then they disappear. And it's because they went into corrections and that treatment provider never heard anything from corrections about what was happening to their patient. And they only see them, a year or so later, and it turns out, oh, they've actually had hepatitis C treatment now, but their care provider in the community was completely left out of that. And it's kind of a missed opportunity, because knowing that someone in corrections is eventually going to go back to the community, we really should actually be trying to involve those community care providers so that they actually are able to then transition the care back to them. So for example, this would be important for people who have cirrhosis at the time of hepatitis C treatment, because they're going to actually require ongoing monitoring of their liver disease even after they finish treatment. And so trying to ensure that there's someone in the community who's going to pick that person back up and track them and have that warm handover, that's going to involve actually having a relationship with them during the period of custody. And so some simple ways that can be done is having a template, just a basic letter that you can then just fax to them to say, hey, look, we've got your client, he's in custody, we're ordering some more tests, we'll copy you on them, do you want us to do anything else? Things like that actually could make quite a large difference in terms of coordinating care. Which leads to the next point is we heard quite a lot of emphasis from stakeholders, particularly people with lived and living experience, around their preference for consent to be obtained before testing is ordered. This is particularly with regards to the British Columbia opt-out HIV testing. People kind of identified that whatever was the standard of care in the community should be the standard of care in corrections. Now, informed consent was identified as something that participants felt was, kind of a human right, and that they should always be told that testing is being offered, what they're being tested for, and in fact, participants decided that they should actually be able to choose which tests they have, so that it's not an STBBI package that you have to say yes to all of them, but you can actually decide which ones you want and which ones you don't want. And in fact, the experts, the stakeholders who were involved in hepatitis C treatment and other infectious disease physicians also agreed that having a panel that people can choose which ones they want would be important. And in terms of being able to actually minimize the amount of kind of work that's required, there was actually a lot of agreement that we could have what we're calling an express consent option, because a lot of the people with lived experience of incarceration who we spoke to said, I've been tested for these things before, like I know what they are, and you don't have to have a big in-depth conversation with me to tell me, about HIV treatment or things like that. I know what I'm signing up for. And one of the ways that we could actually expedite this process is essentially at the time when testing is being offered, for the two options to be presented to say, are you happy to proceed with this? Do you need any more discussion? If not, we'll book an appointment for you to have your blood drawn right away. Or like, is this something that you want to have a bit more of a discussion about? And by having that appointment that's being made within 24 to 72 hours after intake, that would actually be possible for clients to be able to choose. And we've also identified that having some standard symptom screening surveys at the time of test offer could also be really helpful to triage clients for further follow-up, so that those clients would be able to be seen by an MD or an MP kind of much faster rather than waiting for the results to come back. And so kind of integrating those two things into the testing procedure, we think will be really important. And the other thing that all of the stakeholders agreed is actually really, really important to emphasize is that arranging linkage to care and planning for discharge should actually happen at the time when testing is being offered. This might seem a little bit counterintuitive because you don't necessarily know that the client needs to be linked to care for anything. But given that, up to 40% of people in corrections actually might be living with hepatitis C infection, it's probably not a huge waste of time to actually ensure that these processes begin at the time of testing offer. So the first thing that we're recommending is actually having a standard release of information consent form, if that's not already available, and asking clients to sign it if they're proceeding with the STBBI testing, explaining to them that this form allows you to share their information with a healthcare provider in order for you to link them to care. So sending an automatic referral for hepatitis C treatment if the hepatitis C test result comes back positive. And it means that as soon as you are giving them their results, you can tell them we sent the referral already to Dr. X, and your appointment is going to be next week to discuss the treatment options with them. This also means that you can share their contact information with the community care provider when they're being released. And you can also ensure that any other results that can be copied to, say, for example, if someone has a regular OAT provider in the community, you can also copy them in. And then whatever pathway you have at a correctional centre in terms of actually having access to hepatitis C treatment or prescribing, thinking about involving a community care provider at the same time, if that person is not actually a care provider in the community, will be really important to have a plan in place for release. And the participants identified that the method that's being used in BC Provincial Corrections for OAT at the moment, they actually found that highly acceptable and recommended that we should consider doing this for STBBIs as well. So they have a transitional care team, and they actually begin referring clients to the transitional care team as soon as they begin the OAT intake process in corrections. And it includes setting up housing, transferring medical care to an OAT provider in the community, providing transportation for them to get to the appointments and linking them to other support, and ensuring that they have an appointment made with the community care provider when they're getting released from corrections. One of the participants in a focus group said that the follow-up care and support system is more important than the method. And what they were referring to is that, no matter which way we're providing STBBI testing and how we're doing it, having the follow-up care and that emphasis on linkage to care and treatment is the most important part of this whole sort of algorithm. There was also a lot of people who said that they had been tested for an STBBI in corrections and that they never got the result back. And so there was a lot of emphasis from the participants on the need to return all test results, no matter what the result was. So identifying multiple methods to receive results. Participants told us about these kiosks that are in some of the correctional centres, and we've identified that healthcare actually would be able to make negative results available in the kiosk. It's a confidential way that's only accessible through biometrics. So people who are in custody would actually be able to securely see their own results in the kiosk. People also shared that they would be happy to receive an email, and that while a lot of them might not necessarily have a phone at the time, a lot of them are accessing email and things like that once they get out of corrections. And so if the results were there of waiting for them, they'd be happy with that, as well as having like a letter in their belongings, which they collect when they're getting released. And really, really key to all of this is creating documentation systems. So a lot of correctional centres were not tracking the tests that were performed or what the results were. And so they had no central way of actually being able to say, this is how many people right now that we tested and that actually tested positive for each of the STBBIs. And so in order to actually streamline all of these recommendations, it's really important that the tests being offered are tracked some way, the tests that are performed, the results, then tracking if the results are returned to the client, and then if treatment is commencing and what the treatment is, having a documentation system for all of those pieces is really important. Whatever it is, that's not the important part. The important part is that it exists. We do have some examples of templates on the website that can be used, but it's up to the correctional centre to decide what's going to work for them. And then streamlining the workflows across all of the correctional centres. So we've created a protocol that ensures STBBI testing, linkage to care and treatment is consistent across all of the correctional sites in BC. And the stakeholders identified that this would be really important to improve continuity and reduce gaps in care. And it's a team-based protocol, so it actually identifies various different people who are part of the correctional healthcare team who are responsible for different tasks. The protocol includes which tests to order, how to offer them, recommendations for returning positive and negative results to clients, the counselling and harm reduction information to be provided. This protocol ensures that linkage to care is streamlined, and it also has a hepatitis C therapy protocol that's simplified through existing links to specialists through telehealth. So the STBBI testing and linkage to care policy recommendations and guidelines are going to be published in May. You'll find them available on the STBBI Pathways.ca website. This is the website where you'll find the online course for correctional officers and for healthcare providers. So stage 5, implement and evaluate, will be commencing in June, and then scaling and spreading from July and beyond. Hopefully, I think we have time for some questions. I really hope that everybody checks out the website, and please feel free to give us feedback about the website as well. And I'll pop the link in the chat box.
Great. Thank you very much, Dr. Bartlett. That was really an interesting presentation. We do have some time for some questions. So anyone who would like, again, just a reminder that you can put your questions into the Q&A tab. So the first question that we have here is it free to do the fact sheets and questionnaire, and is it also for students? And she was asking where that can be found as well. So I think that's on the website that you just put in the chat. But
yes, so the courses are all free. All of the resources are available through Open Commons as well. So we're very happy for people to use and adapt them. You just need to include like a small attribution. But yes, they're very much open and available, and we really hope that people do access them.
Great. We have another question here with a bit of an anecdote as well. So this is the question. I was in Ottawa and I got my status of HIV test. I didn't even know. They told me that told to me by a guard, and they all of a sudden put me on a special diet of Ensure. With this diet they put me on, it told the whole jail that I was HIV positive. Things like this need to be stopped. Why didn't the doctor or nurse tell me my status?
Thank you for sharing this anecdote. And, we actually heard quite a few concerning things like this from people with lived experience of incarceration. And so, unfortunately, they're not the only person who've had an experience like this. And these types of, procedures or policies of, a special diet for someone who's living with HIV, or receiving medication singled out. These types of things are the things that we're recommending need to be reviewed within correctional centres, to ensure that there is not this kind of default where it's able to be identified. We heard from people that there is often this kind of gossip or sort of conjecture related to different healthcare that people might be receiving. And so, we are really recommending that correctional centres review those types of procedures. We agree that those types of things really should be kind of not necessarily happening in provincial corrections. Obviously, and I think this is a challenge for providing care in corrections. It's not always possible, given the situation that you're in corrections, for the best practices to actually be able to be recommended. And of course, the solution to all of this would actually be, decarceration, not having people in prison in the first place. Unfortunately, as a public health practitioner, I have very little ability to influence the correctional system. So, we all had to think a lot about the things that we had influence over. I hope that the recommendations and the rest of the kind of rationale in the full policy and guideline will actually help to eliminate things like this.
Thanks. We have two more questions, and then I think we'll have to stop for time. The first is it's someone's personal experience as well. I was treated and reached SVR 12 years ago, and I was recently tested for antibodies unbeknownst to me. The doctor suggested that I tested positive, and was there in fact an RNA confirmatory reflex test done to see if I was reinfected, or should I assume not? Nobody contacted me to say.
So, I think there are some cases where people are being tested for STBBIs where they're not explicitly being informed that they're being tested for an STBBI. And we hear time and time again that it causes confusion for patients, and that it's not necessarily the most helpful thing to do to ensure that people are linked to care. So we really do recommend that people are informed about the tests that are being offered, that they're given the opportunity to consent before any tests are ordered, and that all results are returned in a timely manner to ensure that patients do not get confused about the things that they're being tested for, and that they know what those things are, because then they have the agency to be able to actually check when their results are available and things like that, putting the power back into the hands of patients. Not to say that obviously the tests that are being ordered have to be determined by a healthcare provider, they do, but especially in a prison environment where there is a power differential and where people have had a lot of their choice and agency and control taken away from them, ensuring that they actually feel like they have a role in the decision making is probably going to be really important, and giving them the opportunity to actually be in control of their healthcare.
Thanks. And one final question here. In your proposed policy recommendations, are there also plans to standardize in-house phlebotomy or POCT to streamline the testing process?
So that's actually a really good question. We actually had a lot of discussions around the sort of testing methodology and things like that. In British Columbia, unfortunately, point of care testing is not widely available. And so we are recommending to streamline and actually conduct phlebotomy for all of the STBBI testing, particularly because the other tests that we're recommending be ordered can only be done on venous blood samples anyway. That's not to say that individual correctional centres can't make a decision around offering point of care testing as well. However, we are suggesting at the moment, because other tests such as the liver enzyme markers, the complete blood count and things like that, they all need to be done on a venous blood sample. And so having that kind of one and done approach where you just have one blood draw and get all of the tests done at the same time is most likely to actually improve the continuity and reduce gaps. So at this time we are making some recommendations around that, but not to rule out point of care testing, particularly as new tests might become available.
Great. Thanks very much. Yeah, I'd like to thank Dr. Bartlett again for joining us today and for an excellent presentation. We're out of time, but so I'll be closing the webinar shortly, but as you leave the Zoom link, you will get a link to a webinar evaluation. If you could complete that, we would really appreciate it. And the link to the recording and the slides will be emailed to everyone who registered through Eventbrite. They'll also be available at nccid.ca after the webinar. And just to let you know, we do have one upcoming webinar in this series as well, which is going to be exploring opt-out testing in provincial correctional settings, specifically in Alberta. And the speakers for that will be Dr. Rabia Ahmed and Jennifer Graytrix. That'll be on May 25th. So if you're interested in hearing more in this series, then please attend that as well. Thanks, everyone.
Thanks, Susie. Thank you, everyone, for joining.